Good evening. My name is Warren Hall, and I'm the ALF's National Manager of Support Services. And I want to be the first to welcome you to tonight's academic debates presented by the American Liver Foundation. Now, tonight is a historic night because the third debate of this evening will feature an inaugural Associate Medical Professionals debate. Physician assistants and pharmacy residents will debate one another on the long-term use of dual immunosuppression therapies in patients with autoimmune liver disease. But we're excited about all of our topics. We're proud of our teams, and we're grateful for our sponsors and honored to have such an outstanding panel of judges alongside our esteemed moderator, Dr. Brown. And we're grateful that all of you have taken the time out of your busy schedules to join us this evening. We know that you will enjoy it. Tonight's academic debate is being delivered on the Zoom webinar platform, something all of us over these 2 years have come to know and love, I think, and it will be recorded. During the presentations, if you have a question, please hover your mouse over the bottom of your screen and click on the Q&A. Then simply type your question into that Q&A box. For all other comments, and hopefully to cheer on your favorite team, please use that same Q&A box as well. Now, please note also that this program is being recorded, and it will be available on ALF's YouTube channel for future viewing. As I mentioned earlier, we're extremely grateful for our ongoing sponsor support. We're so grateful to our premier supporter sponsors, Abbvie and Eisai, for supporting this 2022 academic debates. Let's hear what our premier supporter sponsors have to say. We are so appreciative of our sponsors' support because without it, we would not be able to continue to fulfill the ALF mission. Now, before I introduce our moderator, I want to acknowledge tonight's technology team, Barb Potter and Karen Irwin. Now, I said before that all of us have come to know and love the Zoom platform, and I'm not so sure about that, but we have two of the best in this area, and we couldn't have this presentation tonight without their expertise. And so we're so grateful to Barb and to Karen. Now, it's time to turn the program over to our moderator for this evening, Dr. Robert Brown. Dr. Brown is the Vincent Astor Distinguished Professor of Medicine and the Chief of the Division of Gastroenterology and Hepatology at the Weill Cornell Medical College in New York City. He received his AB from Harvard College, his MD from New York University, and MPH from the University of California, Berkeley. He did his residency at Beth Israel Hospital, Harvard Medical School, and a fellowship in gastroenterology and hepatology at UCSF. He has co-authored over 200 peer-reviewed articles and is the editor-in-chief for liver transplantation. You can see why he's the perfect moderator for us this evening. Dr. Brown received the Young Investigator Award from the American Society of Transplant Physicians, the Senior Attending Teaching Award at Columbia University College of Physicians and Surgeons, and no doubt the highlight of his career, he received the American Liver Foundation New York Chapter Physician of the Year. Dr. Brown, along with his moderating this evening, will be saying a few words about the history and the format of the debates, and he will explain how you can help support the mission of the American Liver Foundation. He'll talk about how you can promote the debates through our social media, and he will introduce our esteemed panel of judges for tonight's debate. And so, Dr. Brown, I hand the program into your capable hands.
Well, thank you, Warren. I was so proud of being an esteemed moderator, but now it seems like everybody's esteemed. The esteemed technical crew, the esteemed judges, the esteemed Will Smith. No, Will Smith will not be slapping anyone during today's performance. And I do want to welcome you to the second night of the ALF Academic Debate Madness. I know I've been looking forward to this. As much as I've been looking forward to March Madness, which has been so fun, as UNC has pulled into the Final Four and hopefully will triumph over Duke this weekend. The academic debates have not had as long a tradition as the Final Four, but have been hosted by the ALF for over 18 years and have been enormously popular, both in their in-person and now over the pandemic virtual format. They've been recognized for their educational excellence and have become a signature program of the ALF and then adopted by the AASLD. They're our most popular non-CME programs among healthcare professionals in all of our medical fields and disciplines. And I know that I've enjoyed participating at every level, as a moderator, as a judge, and as a mentor. Unfortunately, I never got to actually do the debate because I'm too old. This year, we're doing a week-long March Madness of academic debates, which started on the 28th and will conclude on April 1st. Each team has two fellows and a mentor. And tonight, of course, you heard, we have the pleasure of having our first associates debate. And they all come from the institutions that support our ALF mission. Each debate has 3 judges and 1 esteemed moderator. For tonight, you have the misfortune of having me. The winning teams will be selected based on their research, their presentation of their cases, and the rebuttals. But the judges have been made clear it is not what they think is right, but who argues the better case. A medical advisory committee got together and set forth the subject matter and perspectives that they might argue. This was decided by several of us over multiple calls to reflect the breadth of liver disease that the ALF works on and that we struggle with as academic physicians and healthcare providers. The topics for this week's debates include alcohol-related liver disease, autoimmune liver disease, fatty liver, liver cancer, pediatric liver diseases, and viral hepatitis. There are no rights or wrongs. We really tried to set the topics so that the research, evidence, and perspectives would lead to an invigorating and controversial discussion. We provided criteria for the team members to focus. We've seen their PowerPoints, they're really good. They're gonna both do a pro and a con. They're gonna work on their rebuttal skills. We will see how quickly they can think on their feet during the Q&A. This is a really great way for young trainees to hone their skills. Tonight, we have 3 exciting debates with teams from the University of Wisconsin, Advocate Lutheran, Aurora Healthcare, Einstein Healthcare Network, Northwestern Medicine, and the University of Illinois, Chicago. The topics assigned to the debate teams are chosen specifically because they've not been settled in the medical literature, or they're ethical with no right or wrong answer. Through these debates, we seek to stimulate higher thinking about significant issues that impact the lives of people with liver disease. These are going to be fast and furious, like the Fast and Furious 12 or whatever number they're up to now. We will start each debate with a pro and then the con, and then each team will have 8 minutes. If they exceed, our diligent and esteemed timekeeper will disconnect them. They get the hook. No audio, no video. But we'll try, because they'll try, to transition smoothly. But trust me, I've seen it where they get the hook. It does happen. And then after both, they'll have an opportunity to challenge with a 5-minute rebuttal. No slides during the rebuttal. They will also be timed and have the potential to get the esteemed hook from the esteemed timekeeper. A 5-minute question and answer session led by the judges will follow the rebuttals. Before we start, yes, we will announce winners. And of course, when you have a winner, you do have a loser. There is no prize for participation, but we do think that there is a prize for participation. We acknowledge the demanding work of our presenting team and their mentors. We know they're going to get a lot out of it, and I'm sure it will be close. And we want to express our appreciation to our sponsors for their financial support, to the judges, timekeeper, and technology team, all of whom have volunteered their time this evening to help with this. And importantly, we thank you, the audience, for joining us this evening. So, part of the reason you're joining us is to learn. Part of the reason you're joining us is we're hoping that you're going to help us reach our fundraising goal, which is $5,000 tonight. The American Liver Foundation has been a trusted voice for liver patients for 46 years. Its leadership and staff always strive to ensure that the foundation is a reliable resource for patients, caregivers, and medical professionals. The educational program has been presented consistently, and particularly during the pandemic, ensuring that people have access to information about myriad liver disease topics. I know that you, most of you, like me, send your patients to the ALF for education. The programs that they provide are recorded and uploaded to the YouTube channel so that people can access them and view them if they miss them or want to see them again. Printed literature has been created and updated, as has our web pages about liver disease and transplant. And all of these resources are available at no charge to the public. Their national helpline is a vital source of assistance for people who want and need information about medical diagnostics, liver diseases, and links to financial aid, patient and caregiver support, and more. Their advocacy efforts, both locally and on Capitol Hill, make sure that issues pertaining to access to care and treatment remain a priority for legislators who make decisions about healthcare policies. So how do we do that? Well, you need money. And we raise money through a variety of things. The walks, you'll hear about the walks and the marathons, and patient and professional education programs that help them raise money for these events, and we cannot do any of this without your generous support. ALF is a not-for-profit, and it relies on donations to carry out its mission. Please be as generous as possible and help the ALF continue to provide these critical resources to patients and caregivers. As I said, tonight's fundraising goal is $5,000. Any and all support is greatly appreciated. Before I introduce the topic and the team members, it is my privilege to introduce our outstanding panel of judges. These judges will join us at the conclusion of each debate to ask questions and eventually provide us with the winners. All right, let's start with the judges. In no particular order, I'll start at the right and go to the left just to throw a monkey wrench in. Dr. Cameron Qureshi is an associate professor in the Department of Internal Medicine in the Division of Gastroenterology and Hepatology at St. Louis University School of Medicine. He is a member of the AASLD, the EASL, the AGA, and the American College of Gastroenterology. Dr. Gunn, on the other opposite side, is a gastroenterologist and hepatologist who focuses mainly on finding therapies for liver-related illnesses. She is also a principal investigator in the Association of Clinical Research Professionals. Her work concentrates on linking cutting-edge clinical trials in NAFLD and GI diseases to the population who desperately need them. She is board certified in both internal medicine and GI, and has a broad clinical research and community practice background. Finally, Dr. Balakrishnan received her BA from Rice, her MD from Harvard, and her MPH from the Harvard School of Public Health. She completed a residency in internal medicine at Yale, where she was the chief medical resident, stayed to do her fellowship at Yale in gastroenterology and hepatology, and is currently an assistant professor at the Baylor College of Medicine. Thank you to all of our judges for spending the time and for your insights in advance. The key clinical question for our first debate is whether or not bariatric surgery should be the first-line therapy for obese patients with diabetes and advanced fibrosis. So we're going to do this through a case study. A 45-year-old woman with a BMI of 38, type 2 diabetes mellitus, and biopsy-proven NASH with stage 3 fibrosis. She has a long history of obesity and inability to lose weight. Her hemoglobin A1C is 7 on metformin. She has no complications of her diabetes other than NASH. Her labs reveal a total bilirubin of 0.8, an AST of 60, an ALT of 58, alk phos 98, INR is 1, platelets are 280,000. Her ultrasound notes hepatic steatosis, mild hepatomegaly, and no splenomegaly. So what's next for her? Bariatric surgery, yes or no? As a reminder, the pro will be 8, the con will be 8. Next, we will welcome the rebutters separately, and they will each have 5 minutes to refute the opposing team's presentation. Then, on come the judges for the Q&A. So, let's start. The pro team will be the University of Wisconsin. The con team, Advocate Lutheran General. So let me introduce the debate teams. Go back one. Presenting the pro condition. That was the first one. I'm sorry, you got a little ahead of me. Is from UW, their mentor, Adnan Said. The fellows, Dr. Jessica Musto and Dr. Dylan Stanfield. Next, the con team, Advocate General, will argue bariatric surgery should not be used as a first-line therapy. And their mentor is Dr. Ken O'Riordan. And the fellows representing Advocate Lutheran are Dr. Assad Munis and Dr. Kaushal Majmudar. So let's, I'm going to stop my slide sharing because now we're going to hear from Dr. Jessica Musto from the University of Wisconsin, who will present her position. Esteemed timekeeper, are you ready? You may begin.
Hi, my name is Jessica Musto, and I'm one of the University of Wisconsin debaters, along with my co-fellow Dylan Stanfield. I'd like to thank the American Liver Foundation and our sponsors for making this event possible, as well as the judges, moderator, my opponents, and our mentor, Dr. Adnan Said. The position we're taking is that bariatric surgery should be first line for obese patients with diabetes and advanced fibrosis. As Dr. Brown mentioned, the specific case we'll be discussing today is a 45-year-old female with BMI 38, type 2 diabetes, and biopsy-proven NASH with stage 3 fibrosis. So what do we know about NASH? We know that weight loss is the best treatment for NASH. In a randomized controlled trial testing the effects of weight loss on NASH, those who were able to lose at least 7% total body weight had significant improvements in NASH histologic activity scores, and the percent weight reduction significantly correlated with improved scores. We know that the NASH histologic activity score incorporates steatosis, lobular inflammation, and ballooning injury, and higher scores correlate with greater risk for fibrosis as well as cardiovascular disease. In a prospective study of patients with biopsy-proven NASH, they found a similar correlation between weight loss and histologic improvements, but also showed that those who lost at least 10% total body weight also had regression of fibrosis. Unfortunately, we also know that weight loss with lifestyle modification alone can be incredibly difficult. In that same prospective study of patients with biopsy-proven NASH, patients were followed over the course of a full year with intensive lifestyle modification counseling and oversight. Regardless, they found that less than 10% of patients were able to lose 10% of their body weight, and the grand majority of patients, over 70%, weren't able to lose 5% of their total body weight. The National Health and Nutrition Examination surveys between 1999 and 2006 showed similar results regarding long-term weight loss and maintenance in the US. Less than 1 in 6 adults were able to lose and maintain a weight loss of 10% body weight over the course of a year with any sort of diet or exercise regimen, commercial, hospital-based, or otherwise. Fortunately, we know that from a number of studies that bariatric surgery can lead to greater and more sustained weight loss. In a randomized clinical trial of bariatric surgery versus lifestyle modification, they showed that on average, patients who had Roux-en-Y gastric bypass were able to achieve and maintain a 25% body weight reduction, shown in the blue line on the graph. Those who had gastric band surgery were able to achieve and maintain 15% body weight reduction, and those who went through intensive lifestyle modification were only able to lose 5.7% of their body weight. And similar results have been found in other surgeries of bariatric surgery versus lifestyle modification. We also know that bariatric surgery specifically improves NASH. In a prospective study of NASH patients who had serial liver biopsies over 5 years, they found that those patients who were able to achieve at least 10% total body weight loss had a 63.2% rate of fibrosis regression. When they looked at those who had bariatric surgery, 47.4% of patients were able to achieve fibrosis regression, whereas only 4.5% of patients who used lifestyle modification were able to achieve fibrosis regression. In a prospective study of 180 patients with biopsy-proven NASH, 5 years after bariatric surgery, NASH resolved without worsening fibrosis in a whopping 84% of patients. In addition, fibrosis decreased in 70% of patients and disappeared altogether in 56% of patients. You can see in this middle figure where the dark brown is F3 fibrosis, just as in our patient, fibrosis began to decrease by 1 year and continued to decrease until 5 years post-surgery. We also know that bariatric surgery improves other outcomes. In patients with NASH, cardiovascular disease is the #1 cause of death, followed by liver disease, and bariatric surgery is the only treatment that has been shown to have a positive impact on both. In a large study of nearly 1,200 patients with NASH, the 10-year incidence of major adverse cardiovascular events was 8.5% in patients who had bariatric surgery versus 15.7% in non-surgical controls. And you can see that in graphical form with the blue line being bariatric surgery and the orange the non-surgical controls. The 10-year incidence of major adverse liver outcomes was 2.3% in bariatric surgery versus 9% in non-surgical controls. But how safe is bariatric surgery in this population? In a study on the safety and efficacy of bariatric surgery in patients with advanced fibrosis compared to F1 to 2 fibrosis, those with F3 had slightly longer hospital stays, 4 days versus 5, but similar rates of complications over the first post-op year. Bariatric surgery is also cost-effective. In a clinical and cost-effective analysis, bariatric surgery was found to be both effective and cost-effective for obese patients with NASH, regardless of fibrosis stage. It was also found to be cost-effective even in overweight patients with NASH and F3 fibrosis. The incremental cost-effectiveness ratio for bariatric surgery ranged from $12,000 to $30,000 per quality-adjusted life year for all stages of fibrosis. What happens to patients with NASH and F3 fibrosis without weight loss? In a prospective study of 1,700 patients with NASH followed over 10 years, the incidence of liver-related complications increased with increasing fibrosis in a nonlinear fashion, with a steep increase from F3 to F4 fibrosis. You can see that over time, those patients with F3 fibrosis in blue and an increasing incidence of liver-related complications and death, quickly approaching that of those with cirrhosis over 10 years. Compared to F0 to 2 fibrosis, F3 had a hazard ratio of 5.8 for liver-related mortality. So our main points: weight loss is the best treatment for NASH, but it's difficult with lifestyle modification alone. Bariatric surgery leads to greater, more sustained weight loss, resulting in improvements in NASH, liver-related outcomes, and cardiovascular risk factors. Bariatric surgery is safe and cost-effective in F3 fibrosis, and without it, NASH can progress quickly to decompensated liver disease and death. So what would life look like for our patient 5 years later without bariatric surgery? At this point, she's 50. She's only been able to lose about 5% of her body weight with lifestyle modification, so her fibrosis has progressed to decompensated cirrhosis. She's being evaluated for liver transplant, but there's concern that her cardiovascular risk factors will make her surgery very high risk. If she's able to get through the surgery, her metabolic risk factors will only get worse with immunosuppression, and she'll be at a greater risk for cardiovascular disease. With that, I'd like to thank you for your time and turn it over to our opponents.
Oh, that was great. Jessica, fantastic job. I think if I were the con side, I'd be quaking in my boots because that was really well said and perfect on the timing. So now we're going to have to see. Let's bring up Dr. Assad Munis. Hopefully I pronounced your name correctly, from Advocate Lutheran, who will provide the con position. Esteemed timekeeper, are you ready? You may begin. Good luck, Dr. Munis.
Good evening.
You're muted.
Thank you. Good evening. Thank you to the American Liver Foundation for the opportunity to participate in today's event. We will be presenting the argument that bariatric surgery should not be first-line therapy for obese patients with diabetes and advanced fibrosis. Specifically for this case, a 45-year-old woman with a BMI of 38, type 2 diabetes, and biopsy-proven NASH with stage 3 fibrosis. Non-alcoholic fatty liver disease, or NAFLD, is the most common cause of chronic liver disease worldwide, with a global prevalence of about 25%. The overall prevalence of NASH among patients with diabetes is about 37%. And among biopsy patients with NAFLD and diabetes, 17% have advanced fibrosis. In a recent meta-analysis performed by Dr. Balakrishnan et al., there's evidence that suggests women with NAFLD have a 37% higher risk than men for advanced fibrosis. NAFLD encompasses the entire spectrum of fatty liver disease in individuals without significant alcohol consumption or other causes of hepatic fat accumulation. NASH is thought to be a relatively indolent and slowly progressive disease. After the diagnosis of NAFLD is made, it is felt that up to 25% of patients have progression to fibrosis within 5 years. And in a recent study by Sanyal et al. In the Journal of Hepatology in 2019, there's some suggestion that it takes a couple years for even a small proportion of individuals to have further progression. There have been various studies focusing on non-invasive fibrosis tests, specifically in the diabetic population, but most of the data has been extrapolated from larger studies that included both diabetic and non-diabetic patients with NAFLD and NASH. Non-invasive serum markers and imaging modalities only have modest accuracy to guide clinical management decisions, and the optimal combination of parameters to accurately predict outcomes or reflect changes in disease states remains to be determined. The presence and extent of fibrosis in NASH is the only histologic feature proven to be clearly associated with adverse outcomes. However, to accurately diagnose this involves the imperfect method, a liver biopsy, which has its own drawbacks. Importantly, sampling error and inter-observer disagreement in the estimation of the extent of fibrosis. This raises the possibility that we may not be even accurately capturing our target audience. In addition, various histological staging criteria are utilized in clinical trials due to the lack of standardization, such as the NASH CRN, EPO7, ISHAG, and Medivir. A couple of these weren't even designed specifically for NASH fibrosis, but are still used in the trials nonetheless. In essence, there's lack of standardization for identifying patients with F3 fibrosis. Now, let's dive into the data that we have that supports against the use of bariatric surgery as first-line therapy. But first, as a quick refresher on scientific evidence, systematic reviews and meta-analyses are the strongest. They carefully comb through the literature and avoid the trap of relying on any one particular study. Randomized controlled trials are considered the gold standard of scientific research. They are the most powerful experimental design and provide the most definitive results. Then there are observational studies that attempt to find causations. So let's dive into the data. This is a meta-analysis performed by Lee et al. In Clinical Gastroenterology and Hepatology in 2019 that included a total of 15 retrospective and 17 prospective studies published between 1995 and 2018. More than a third of the studies reported worsening or new development of fibrosis. 12% of the patients pooled from 19 of the studies developed or had a worsening of NAFLD-related side effects, such as fibrosis. Need I say more? Well, since I have the time, I might as well. So let's go into the next strongest data that we have, which are randomized controlled trials. You may be thinking I'm having technical difficulties, but I'm not. There are 0 randomized controlled trials that assess the hepatic histological effects of bariatric surgery, or BS, in NAFLD patients with advanced fibrosis. And yet our friends in Wisconsin want to use BS as first-line therapy. Now, I wish I could share with you stronger data, but since it doesn't exist, I can show you the data that does further support against the use of bariatric surgery for NASH and advanced fibrosis. Pais et al. In the Journal of Hepatology in 2022 performed a retrospective analysis of patients who underwent bariatric surgery. 36 had advanced fibrosis at baseline. Follow-up was performed at 1 and 5 years post-bariatric surgery. They revealed that 47% of these patients with advanced fibrosis still remained with advanced fibrosis despite NASH resolution more than 5 years after surgery. Call et al. In the Journal of Obesity Surgery in 2020 performed a retrospective analysis of patients with advanced liver fibrosis undergoing bariatric surgery at a tertiary care center. Transient elastography and liver biopsy findings 1 year after surgery were compared with baseline. 29% remained with advanced fibrosis on follow-up liver biopsy. 57% showed worsening stiffness on follow-up transient elastography. And if you look closely, 29% of these patients who supposedly had improvement of their fibrosis actually had worsening in their stiffness score. Mathern et al. In the Journal of Gastroenterology in 2009 performed a prospective study that evaluated long-term evolution of fibrosis 1 year and 5 years after bariatric surgery in about 380 adult patients with NAFLD. They found that 20% of patients showed fibrosis progression 5 years after bariatric surgery. And if we look at the data even closer, we'll see that the patients who had F3 at baseline still had F3 even after surgery. Titano et al. In the Journal of Gastrointestinal Surgery in 2015 performed a retrospective study of 160 patients undergoing bariatric surgery. Of the patients with grade 3 fibrosis on initial biopsy, progression of fibrosis occurred in 14% of these patients and remained the same in 29% of these patients. And if we look at the rest of these patients, 12% had progression of fibrosis to a higher grade, 21% developed de novo fibrosis. Now, I could go on and on about how BS should not be first-line therapy, but lucky for some, I was only given just a couple minutes to share all this data. So here's a snapshot of some of the other studies that re-emphasizes the fact that it is unrealistic to expect high rates of fibrosis reversal for these millions of people. Now, I obviously can't end this discussion without commenting on the myriad of complications that occur after these operations: anastomotic leaks, nutritional deficiencies, Barrett's esophagus. It should be noted that in patients with advanced fibrosis, there is a substantial risk of morbidity and mortality in this patient population. Therefore, we should consider non-invasive interventions first before bariatric surgery. Given its complex and dynamic pathophysiology, there's no doubt this disease requires a combination of sequential and personalized treatments. Thankfully, we have pharmacological interventions that could be a more effective therapeutic option and should be better integrated into a patient's personalized care plan. So I ask you, could you ever go against our professional society? Currently, there are no specific recommendations regarding NASH and F3 fibrosis. The data that currently exists is not sufficiently strong enough to recommend bariatric surgery as first-line therapy. It's premature. We don't even know which type to use and whether it's safe or effective. In conclusion, large randomized controlled trials with long-term follow-up are needed to demonstrate the beneficial effects of bariatric surgery and to identify a definitive role of bariatric surgery in NASH patients with advanced fibrosis. The data that exists stems from weak studies. To recommend this therapy with high risk of complications is premature, and presently, lifestyle interventions and pharmacological agents remain the preferred initial therapy. Thank you.
Now I'm perplexed. That was such a fantastic presentation as well. Now I don't know what to do. Do my patients get an operation or not? Hopefully our rebutters will make this clearer. So we're going to start with Dr. Dylan Stanfield from the University of Wisconsin, who will now swing me back to the side pro-surgery, because I'm against you now.
Thanks a lot, Dr. Brown. And thanks to our opponents for presenting their side of the arguments. I'll now be addressing those points in our rebuttal, and hopefully it can help you reach the conclusion that bariatric surgery is the safe, efficacious, and cost-effective modality for weight loss in obese patients with F3 fibrosis and diabetes. While our con friends make some valid, excellent points, we think this topic becomes much more simplified when you boil it down to the three basic tenets of any drug or medical intervention, which also happen to be the three basic tenets of Shark Tank. Is it safe? Does it work? And is it cost-effective? We hate to bring the awkward topic of money into discussion, but when we are in a time where a gallon of gas is approaching minimum wage, we find it to be especially prescient. Regarding the cost argument, liver transplantation, which also happens to be a treatment modality we perform without any randomized controlled trials to prove efficacy, is an expensive treatment. And until Elon Musk develops a Tesla liver, unfortunately, it's also a very finite resource. Cirrhosis, decompensation, and cancer are expensive to treat. HCC surveillance and cirrhosis care especially are extraordinary burdens to the healthcare system. NASH F3 treatment should be analogous to treating HCV before cirrhosis to prevent the progression to cirrhosis and its litany of complications. Regarding cost effectiveness, just touched on this earlier, but bariatric surgery has been shown to be both cost effective and safe in patients with NASH and compensated cirrhosis. In the simulation study published in the JAMA Network Open in 2019 by Klebanov et al., the results showed that bariatric surgery would outperform usual cares and intensive lifestyle intervention. And despite the increased risk of decompensation at higher BMIs, weight loss led to decreased portal hypertensive complications associated in lower BMIs. And our previous presenters, our con opponents, they talked about going with different options before we consider bariatric surgery, but we know that fibrosis is not a linear correlation. Previous studies have demonstrated that progression through F1 to F4 fibrosis does not follow a linear correlation, and evolution from F3 to F4 can occur at a much faster rate. Thus, by the time that bariatric surgery would be considered down the line after they've failed these other methods, the patients will be a more complicated surgical candidate and perhaps even excluded for this reason. So our bariatric surgery safe? We know these surgeries should be done in an experienced center with set standards. Roux-en-Y gastric bypass versus sleeve gastrectomy, with exclusion of some of these older surgeries like biliopancreatic diversion, jejunal-ileal bypass, which carry much higher complication rates such as malnutrition and decompensated liver disease than these newer methods. And regarding the overarching question of safety, given the progressive nature of NASH and in patients with obesity and type 2 diabetes, the argument really shouldn't be about the safety of bariatric surgery versus conservative measures. The true comparison should be regarding the safety of bariatric surgery versus liver transplantation. One carries a 99+% one-year mortality versus the other being 93 to 94%, even in an experienced transplant center. When considering effectiveness of bariatric surgery versus medications that our opponents brought up on a slide, numerous studies have shown it's a superior option for weight loss, but what about NASH and fibrosis? There's undoubtedly more impressive data for significant fibrosis regression with bariatric surgery and over the long run than any medication in phase trials or FDA approved currently on the market today. Dr. Musto talked about Leslie et al. Published in Gastroenterology in 2020, which demonstrated bariatric surgery provides long-term resolution of NASH and regression of fibrosis. Resolution of NASH was observed at 1 year in 84% of patients. And even in patients with baseline bridging fibrosis, there was complete absence of fibrosis seen in 45% of that subset, which is a big deal. The improvement and resolution of fibrosis continue from 1 year to 5 years post-bariatric surgery. Regarding the only medication that has shown any reversal or downstaging of fibrosis, obeticholic acid, interim results from their phase 3 trial, they did show improvement in one stage of fibrosis without worsening of NASH. However, we think that study had significant limitations, including they primarily combined their fibrosis reduction data, both between F2 and F3 fibrosis, which obviously should put their results into more context regarding efficacy. There was no NASH resolution difference between obeticholic acid and placebo. And of course, none of these results are final given the phase 3 nature of the study. Other medications like semaglutide and the GLP-1 agonist, which is currently in a phase 2 trial, these either show no change in fibrosis or only mild resolution in NASH features at 12 to 24 months. And regarding the safety of this drug, and a consideration for all the newer medications used for NASH and obesity, a systematic review and meta-analysis published just this week in JAMA Internal Medicine showed concerning associations between GLP-1 agonist use and risk of gallbladder and biliary disease, something that could be a catastrophic outcome in our patients with already underlying advanced fibrosis or cirrhosis. This association was especially prevalent when using this drug at higher doses, longer duration, or for weight loss, which would be our discussion today. Along with its benefits in fibrosis, many studies have shown bariatric surgery to be very effective in treating diabetes, high blood pressure, sleep apnea, high cholesterol, as well as reducing death from cardiovascular disease and malignancy. So in conclusion, given the safe, effective, and cost-friendly nature of bariatric surgery in patients with F3 fibrosis, obesity, and diabetes, we feel that this should be first-line therapy in patients who are undergoing this intervention in experienced and capable hands. This process has truly been a pleasure, and I thank you all for your time tonight.
Well, I do not envy the judges who will have the difficult time of figuring this out. If this was a Final Four game, I would think it was going to go into overtime, double overtime, triple overtime. It's so close. So let's bring up our other rebutter, I guess rebuttee, Dr. Majmudar, who will rebut the University of Wisconsin position and convince us why we shouldn't be operating on NASH with fibrosis.
Good evening, everyone. My name is Kaushal Majmudar. Thanks to everyone for taking the time to participate in this exciting and educational event organized by the American Liver Foundation. To my colleagues at University of Wisconsin, Dr. Musto and Dr. Stanfield, thank you for presenting this very interesting data regarding bariatric surgery in patients with NAFLD and NASH. I enjoyed your presentation, Dr. Musto, and it was impressive regarding the utility of bariatric surgery in patients with NASH. But let's focus on the question we were actually asked. We were asked whether there's sufficient evidence to recommend bariatric surgery as first-line therapy for obese patients with F3 fibrosis and diabetes. Now, you presented some very interesting studies, but guess what? Patients with F3 fibrosis comprise just a small fraction of the cohort in each of these studies, some of them as few as 10 or 20%. Some of the studies don't have any patients with F3 fibrosis and instead have patients with mild F1 or even F2 fibrosis. Nearly all the data about bariatric surgery and F3 fibrosis are from post hoc analyses or secondary endpoints in retrospective or observational studies. For instance, they presented a study by Dr. Lysali et al. From 2020 showing NASH resolution and fibrosis improvement. But guess what? Only 20% of those patients had F3 fibrosis that had the 5-year follow-up. So they're taking an outcome with the patients that don't predominantly have F3 fibrosis and applying it, which is not an accurate thing to do. The most of the fibrosis resolution that occurred in that study occurred in patients with F1 or F2. So you can't apply that outcome to our patients. They presented a study from JAMA looking at cardiovascular outcomes published in 2021 regarding cardiovascular outcomes in patients undergoing bariatric surgery. But guess what? none of these patients underwent a liver biopsy to objectively assess fibrosis response at the end of this data. And only 20% of these patients had F3 fibrosis. Over half of them had F1, 51% had F1 fibrosis. Not to mention in their data, 10% of patients had major adverse events within 30 days of the bariatric surgery, including sepsis, pulmonary events, thrombosis, bowel obstruction, cardiac events. So this is just one example of why data like this is not sufficient to recommend this as first line. As Dr. Munis said, there was the recent study by Dr. Pais et al. From hepatology that only looked at patients with advanced fibrosis, where the majority of the cohort had advanced fibrosis. And their data showed that 47% of patients with advanced fibrosis did not improve with bariatric surgery on a repeat biopsy 5 years later. And that's despite improvement in diabetes and resolution of steatohepatitis in biopsy. So while much of the data presented by my colleagues at University of Wisconsin is impressive, it's not directly applicable to the question at hand. And actually, as my colleague Dr. Munis mentioned, there are multiple studies where patients worsened. One study by Dr. Mathurin was 20% of patients had worsening of fibrosis for unknown reasons. A meta-analysis with 12% of patients with NASH who got bariatric surgery that got progression of disease. So my question to my colleagues at University of Wisconsin is, how are you going to identify these patients? How are you going to predict who will benefit and who will worsen if they undergo bariatric surgery? And until you can better risk stratify this, how can we recommend this as first line therapy? And let's remind ourselves, they presented 0 randomized control trials about bariatric surgery and F3 fibrosis. The randomized control trial they presented was just about patients with diabetes and obesity who underwent bariatric surgery and had weight loss. There were no patients with NASH fibrosis in that study at all. All the data they've presented is retrospective or observational, which is just prone to so many different types of biases: publication bias, selection bias, observer bias, imprecision, inconsistency. And in the absence of high quality data, which comes from randomized control trials or meta-analyses of randomized control trials, how can we make an evidence-based recommendation? It's nice that they're interested in the cost of care, but that's not the question we're being asked. They brought up obeticholic acid or semaglutide, but we're not even specifically recommended these medications. We're here to talk about whether bariatric surgery should be first line. So to summarize, this data is interesting, but we do not yet have sufficient data to recommend bariatric surgery as first line therapy for patients with F3 fibrosis and diabetes. Thank you.
Thank you all. This was really great. A great start to our debates. We're going to begin the Q&A. We're going to welcome our judges and both of our teams. They should all join us center stage, turn on their cameras, and we'll begin. Who wants to ask our first question? Dr. Gunn.
Yes, I want to say that both teams did a fantastic job. It was very impressive the way you handled the data on both sides. Just as we know, as we study NASH, we know that possibly when we do find a treatment, it's going to be combination therapy. We're going to need some weight loss and some other things to help mitigate the comorbidities. But I want to ask you, what would change your mind on either side? On the con side, what would make you consider bariatric surgery as a first line, and on the pro side, because it is a conversation that's evolving, and I would love to know where your position would be if you had to think of it on the opposite spectrum.
I'm happy to answer that question for our side. Thank you for that question, Dr. Gunn. I think what we would need is just more data. That includes a couple things. That includes data that is multi-center, where people who are studying the outcomes are not necessarily knowing what group these patients are undergoing. And such trials are actually underway. There is a randomized control trial occurring right now in Italy, where they're randomizing them to Roux-en-Y, sleeve gastrectomy, or lifestyle and medication. So there are these trials underway to help guide us better with an evidence-based basis for how to help these patients. And then the other part is, I think we need longer term data. The median, in these meta-analyses, the median trial length for these studies is 15 months. There's only a handful of studies where they look at these bariatric surgery outcomes 5 years later. And I think we need more data at 5 years and more data longer than 5 years because we don't know yet how this is going to affect progression to cirrhosis, transplant outcomes. So the longer term data of persistent fibrosis after bariatric surgery is not yet clear. And until we can understand that paradigm better, I think it's hard to make this recommendation at this time.
Thank you.
Remember, esteemed audience, you can also type questions in and we will ask them. Maya, do you want to ask the next question?
Yeah, absolutely. That was so much fun. I especially loved the labeling of bariatric surgery as BS. I've never heard that before, and I'm definitely going to use that one. So I have a question for each group. So first for the Advocate Lutheran group, here's your question. So the patient in question here is this woman who has complications from obesity, BMI 38, she has diabetes, and she happens to have F3. We know that she meets indications for bariatric surgery, right, for other reasons. So do we really need fibrosis outcome data? Why does that matter in a patient who would otherwise benefit? And the question for the Wisconsin group is the Lutheran group made a great case showing that not all NASH F3 progresses to bad outcomes. And in fact, there's a subset of bariatric surgery patients who progress more quickly because of the rapid weight loss. So given that, do you still recommend a blanket policy for all patients with F3, or do you see a role for better personalizing the decision? So first, we'll start with the Lutheran group.
Great, thank you, Dr. Balakrishnan, for that question. So I'll answer the question sort of in two parts. One about our patient, who would she benefit from bariatric surgery? So, you know, I believe that the patient, they said that she struggled to lose weight. So I think at least a first step would be to answer what has actually been done. Has she had physician-guided weight loss? Has she been seen in a nutrition clinic? Whether that was just her trying to lose weight on her own is not really clear. And so I think at least the least invasive option should be at least pursued and optimized before taking her to surgery. Because as the data from just a couple months ago suggests, about half of patients with advanced fibrosis will still have advanced fibrosis 5 years later. And so the hesitation is not that bariatric surgery is not effective for some patients, but whether taking the least invasive and least risky options first and making sure that's optimized before proposing a more invasive and aggressive option. Because the question ultimately is whether bariatric surgery should be first line for all patients with F3 fibrosis. And I don't think the data exists to recommend it as first line.
Yeah, and I'll take for the other side that not all patients with NASH F3 fibrosis progress. I think, you know, the grand majority of patients with NASH and F3 fibrosis do go on to progress. And our opponents mentioned a lot of studies where, you know, after bariatric surgery, they didn't progress. But I'd say a lack of progression is still better than progression to decompensated liver disease. With regard to whether or not we should really jump to bariatric surgery and knowing that some patients don't progress, lifestyle modification is part of the evaluation process for bariatric surgery, and oftentimes they require patients, you know, do an intensive lifestyle modification as part of that process. So I think, you know, moving towards bariatric surgery, starting to have the conversation early and putting them through the evaluation process is a good thing for lifestyle modification if that works, and for bariatric surgery if that's ultimately what's required. And with regard to decompensation, with close follow-up and guidance about how much weight patients should be losing over time, the nutritional supplements they may need, things like that. I think that's a little bit newer. Bariatric surgery used to involve less close follow-up post-op. I think, you know, you could guide patients on how to lose weight safely and prevent those decompensating events. And then we're also not using those higher risk surgeries anymore, the ileojejunal bypass and things like that. So I think with the, you know, at a good center that is experienced with bariatric surgery and uses the appropriate surgeries, you really can have some good outcomes.
All right, last question from our last judge.
All right, thanks. So you guys definitely have convinced me that fatty liver disease is a big issue. It's a growing problem. Its estimates are 25% have fatty liver disease globally, 5% have NASH. And predictions are by 2030, we will be dealing with about 20 million plus people who have NASH in United States, based on the estimates that we have. So the question for UW team if we don't have enough hepatologists to take care of NASH, this many NASH patients, where are you going to find that many bariatric surgeons to do bariatric surgery if you are considering this as a first-line treatment for patients with advanced high-risk NASH, advanced fibrosis NASH? And Advocate Lutheran can suggest to us some other options if weight loss, because weight loss, it looks like we need to do something about it. It is becoming a big issue for us. If we have to achieve weight loss, lifestyle modifications do not work. If you are not saying surgery should be the best first option, then what other options do we have?
Yeah, I think if there's a shortage of bariatric surgeons to try and take care of all these patients, the endoscopic procedures that are sort of coming about recently could be something that is explored, especially things like endoscopic gastric sleeve, because we know the outcomes for gastric sleeve, and endoscopic gastric sleeve would be an option there. We also do, on average 900,000 bariatric surgeries a year, as opposed to, I think it's like 3,000 liver transplants a year. So in theory, you have more availability of bariatric surgeons than you do hepatologists to take care of these patients and prevent them from, progressing to needing a liver doctor, or even regressing to the point that they have no fibrosis, they're a completely normal patient. So I would say that both of those things should be considered.
Thank you, Dr. Qureshi, for that very interesting question. And I think it's a very valid question. It's something we probably deal with, if not on a daily basis, then maybe on a weekly basis. What can we do for these individuals who attempted intensive lifestyle interventions and may not have been successful? And bariatric surgery, as we have stated, should not be first-line therapy. So what can be a use? So like I had mentioned earlier, I believe less invasive is indeed more. Less is more. Currently, there are more than 30 trials registered on clinicaltrials.gov that are in phase 2 stages or greater that may have some promising pharmacological interventions for these patients in the hopes of having some anti-fibrotic activity for them. And that's just one option. We still have other options out there that can be less invasive than doing endobariatrics or surgery for these individuals in attempts to not only reverse their NASH, but even lessen the progression of their fibrosis.
All right, so we're not going to tell you the results now. You got to stay till the end to see who gets. Do you get a rose? I don't watch those. Do you get to get off the island? Whatever the winner gets in reality TV, we're going to see who gets the ALF Cup. But let's move on to debate number 2. The key clinical question for this debate, if we want to bring up the next slide, is whether or not it is time for the MELD sodium score for liver allocation to be modified. As a reminder, pro will be 8, con will be 8. Rebutting, 5 minutes each, and then the Q&A. So let's bring on the pro. The pro will be, next slide, Aurora Healthcare. The mentor is Dr. Abdul. The 2 debaters from the fellows representing Aurora, Dr. Jayal Mehta and Dr. Ritu Mehta. Mehta and Mehta. I hope I pronounced their names correctly. For the con side, arguing that it is not time for the MELD sodium to change, their mentor is Dr. Rossi. They're the 2 fellows representing Einstein Healthcare are Dr. David Yan and Dr. Kathy Williams. So let's start with the pro side. Dr. Mehta, Ritu Mehta from Aurora Healthcare will present their position. Esteemed timekeeper, get ready. You may begin. Gotta go back to the slideshow and unmute.
All right, are you, okay. Oh, well, hello, everyone. Good evening. And let me go ahead and just present this, presenter view. Okay, well, good evening, everyone. Thank you for taking the time to join us this evening. And thank you, Dr. Brown, for the introduction. And yes, our last names are pronounced the same. It is Mehta and Mehta. So my name is Ritu Parnameta. I am a first-year gastroenterology fellow here at Aurora Healthcare in Milwaukee, Wisconsin. And I'm joined today by my colleague, J.O. Mehta, a second-year fellow at our program. Today, my colleague and I are here to not only discuss, but to make it abundantly clear that MELD sodium no longer should be used for organ allocation. Let's first start with a case. So here we have a 57-year-old female. She has a past medical history of type 2 diabetes, hyperlipidemia, and hypertension. She presents with abdominal distension and is found to have decompensated cirrhosis due to SVP as well as acute renal failure. Before we go ahead and calculate the MELD sodium score, let's briefly talk about the scoring system. The initial development of MELD dates back to 2000, when it was initially created by Dr. Patrick Kamath. In 2002, during the time of the Clinton administration, UNOS was prompted to reform the organ allocation system from one related to waitlist time to another based on mortality. This was done in efforts to not only reduce racial disparities, but also to decrease the number of deaths while on the waitlist. In 2016, Dr. Ray Kim developed MELD sodium. So now in 2022, are these calculations still valid? We will briefly discuss each of the components of the original MELD. Okay. Of the three components that correlate with liver transplant survival, only bilirubin and INR portray the synthetic function of the liver. The serum creatinine cap of 4.0 and minimum bilirubin value of 1.0 was actually instituted by UNOS at the time the MELD was adopted, independent of its original creation. In a study by Asrani et al. In Clinical Disease in 2011, findings show a correlation between each individual component and mortality as depicted in this graph. Sodium was found to be an independent predictor of mortality, thus was incorporated into MELD sodium by Dr. Ray Kim. However, most recently, Dr. Ray Kim discusses in one of the Liver Fellow podcasts that sodium does not have a constant impact on the MELD score. Rather, it has a higher impact with low MELD scores as opposed to higher ones. The journey of MELD has been one that has been evolving from initially being developed for post-TIPS mortality to predicting mortality in a broad variety of liver diseases, to predicting mortality post-transplant. Early on in the adaptation of MELD sodium for organ allocation, it was recognized that this is an imperfect system, allowing for some level of subjectivity with the exception points. So what does MELD sodium fail to account for? First of all, we have seen the epidemiology of cirrhosis change in patients requiring transplant. Secondly, sadly, females have been found to be disadvantaged in the MELD sodium system. And lastly, we fail to account for portal hypertensive complications in our current model. At the initial adoption of MELD, the MELD had a C statistic of 0.8, indicating a high predictability of 90-day mortality. However, as depicted in this chart by Gaudry et al., the predictability of both MELD and MELD sodium has downtrended over the past 2 decades. With the advent of HCV curative antivirals, hepatitis C related diagnoses decreased from 32.5% to 12.6% from 2002 to 2016. In addition, there was a rapidly increasing proportion of patients requiring transplant who have liver disease due to alcohol and NASH. This indicates that the applicability of MELD sodium is less relevant in patients with non-viral etiologies, which was validated in a more recent study by D'Amico et al. As many things in life, women find themselves at a disadvantage with this allocation system. When comparing females to male outcomes in a recent study by JAMA Surgery published in 2020, women were 14.4% less likely to receive a liver transplant and 8.6% more likely to die on the wait list compared to their male counterparts. So why are women disadvantaged? There are multiple hypotheses as to why this may be. Most importantly, as depicted by the graph in Allen et al., serum creatinine overestimates the GFR in women compared to men due to lower muscle mass. This results in women receiving less MELD sodium points despite having the same severity of renal disease. In addition, women receive less exception points and have lower heights, which make them less likely to receive a transplant. Lastly, MELD sodium does not account for portal hypertensive complications, which we know do adversely affect survival in cirrhosis. Specifically in Bajaj et al., as seen in this graph, it was noted that higher degrees of hepatic encephalopathy contributed to increased 30-day mortality, independent of additional organ failure. Though it has been argued that it is difficult to implement the subjectivity of these complications into a very objective model, we cannot ignore the effect these complications have on mortality. Kamath et al. Had argued that when adding individual complications to the MELD score, there was little impact on predictability of mortality. However, this study only looked at one specific time point. Whether there's impact on other time points leaves it open to further evaluation. So what alternatives do we have? What is on the horizon? Most predominantly the MELD 3.0, which was developed by our own Dr. Ray Kim, who developed the MELD sodium, which we currently use. It includes female sex and albumin as variables, helping decrease the disparity that we see in females. It decreased the creatinine cap from 4.0 to 3.0 and added relationships, including creatinine to albumin and bilirubin to sodium interactions. So MELD 3.0 is projected to reduce the number of deaths on the waitlist by at least 20 and can reclassify 9% of patients who died on the waitlist. Why wouldn't we prevent death? Additionally, MELD lactate and MELD GRAIL sodium had been created as alternates as well. Although none of these may be the perfect system, one of these could bring us closer to a more equitable allocation system. So let's go back to our patient. And just a reminder, this is a 57-year-old female that has a history of metabolic syndrome, and she's admitted for decompensated cirrhosis and acute renal failure. To note, with the MELD sodium system, she does fall short of qualifying for transplant in time, and unfortunately, this leads to her untimely death. However, with the MELD 3.0, our patient receives the gift of a liver transplant. MELD sodium had relevance at the time of its creation. However, as with the change in time and the change in our patient population and our growing knowledge, it is time to move forward to a new method of organ allocation. We'd like to thank the American Liver Foundation.
This is the timekeeper. Time has expired.
All right. You ran right up to time except for the thank you. But that was fantastic. And I guess I'm sorry I didn't call you both Dr. Mehta. I tried to make you into different names, but now I got it all straight. And I'll certainly get the next one right. So we're now going to go to the con position. Dr. Jan from Einstein Healthcare. Is timekeeper ready? Let's switch over. David, the stage is yours.
Thank you, everyone. Good evening. Thank you for being here. It is my honor and pleasure to present the composition. My name is David Yen. I'm a first-year gastroenterology hepatology fellow here at Einstein Medical Center in Philadelphia. And in the composition, we argue that it is not time for the MELD sodium score to be modified. MELD sodium score is here to stay, because it is a simple, easy to use, objective, and reproducible score that accurately predicts short-term mortality across all etiologies of liver disease, despite the change and shift in the etiology of liver disease over time. Its accuracy allows us to prioritize adult, the transplant waitlist, and there has been a well-documented decrease in waitlist mortality since its implementation.
I think we can't see your slide, so
No?
esteemed timekeeper, can we give him a little extra time? Because I think it was the not stopping the sharing by the former team trying to throw you off your game, David. So I love the bow tie. I'm a bow tie lover myself. So we'll let you start from scratch. And we'll start the timer from scratch once you get your slide shared.
We will start with 8 minutes when you're ready, David.
It is like a basketball game. We have to reset the shot clock because the ball was out of bounds and the timer was still running. All right.
All right. Well, I'm sorry, guys, but let's try this one more time. All right. So once again, my name is David Yed. I'm a first-year gastroenterology hepatology fellow here at Einstein. It is my pleasure and honor to present the con side of the argument. I argue that it is not time for the MEL sodium score to be modified. All right, so the MEL sodium score is here to stay because it is a simple, easy to use, objective, and reproducible score that accurately predicts short-term mortality across all etiologies of liver disease, despite the recent shift in etiologies of liver disease. So it continues to allow us to prioritize adults on the transplant wait list, and has been well documented that there's been a decrease in waitlist mortality. Modification of the sodium, MEL sodium score will not address the sex disparities in liver allocation, partly because I believe they has been inaccurately attributed to the MEL sodium score's ability to assess disease severity. And while there are proposed modifications of MEL sodium score out there, all the models, or all the most recent models, have significant limitations and are not well validated. A proportion of the debate on MEL score modifications have been centered on the waning predictive power of MEL sodium score. And this has been reported by Dr. Godfrey and colleague. As you can see in the graph above, they reported that over time, the C concordance score has decreased from 0.8 in 2003 to 0.72 in 2015. However, in a more accurate statistical analysis carried out by Dr. Kim and colleague, in which sensor time was taken into account, the discriminative ability of the MEL sodium score to predict 90-day mortality did not decline at all between 2002 and 2016. And let's just say that what Dr. Godfrey and colleagues reported are true. Despite the worsening of the predictive power of MEL sodium over time, there has been a well-demonstrated and ongoing decrease in liver transplant waitlist mortality during the same period. And according to the Organ Procurement and Transplantation Network data, overall waitlist mortality has declined from approximately 13% to 10% from 2004 to 2016. This decline has also occurred despite waitlist patients being older and sicker, higher MEL scores than in the past. Proponents of MEL sodium modifications have again questioned MEL sodium score's accuracy in predicting mortality, but this time with regard to the observed disparity between men and women in waitlist mortality and liver transplantation. Locke and colleague conducted a retrospective study that examined over 80,000 adult waitlisted for liver transplant between 2013 and 2018 in an attempt to quantify sex-based disparities in liver allocation. So they found that compared to men, women are 9% likely to die while waiting for liver transplantation and 14% less likely to receive a liver transplant. But what factor is the most strongly linked to this disparity? They reported that organ size mismatch had the strongest association with the difference in mortality and liver transplantation between genders. So experts have argued that this highlights a deficiency in the transplant policy that failed to account for candidates with smaller body statures. This is not a failure of the MELD sodium score to accurately capture disease severity, as patients with small body statures at the top of the list are often bypassed due to the size mismatch. There's currently no evidence showing that increasing the MELD sodium score for patients with small body stature will affect size mismatch outcomes and mortality. So the role of the MELD sodium score is really to inform the organ allocation system of the biological predictors of mortality, independent of the transplant policies and practices that could also affect waitlist outcome. In this case, donor-recipient organ size mismatch. Ensuring equity in setting with limited resources is a challenge. I've stated before, the current model prioritizes those with the greatest medical urgency. Critics of the MELD sodium score in general believe that the current score is incomplete and underestimates disease severity in certain populations. As such, new models were created by adding more variables to the MELD sodium equation or by renewing the coefficient of the MELD sodium equation. The most contemporary models, as you can see here, MELD GRAIL, frailty, MELD Plus, and MELD 3.0. All these aforementioned models have significant limitations, and so far none of them have been validated to be superior to the MELD sodium score. Okay. In the frailty model, there's been evidence or increasing evidence that frailty and sarcopenia have been associated with worse survival outcomes. So it is logical to incorporate this particular component to the MELD sodium score. However, there's no standardized objective measurement of frailty or sarcopenia. So the limitation really brings us back to pre-MELD era where subjectivity was an issue. In the MELD GRAIL, the MELD GRAIL model, in which the serum creatinine was replaced by estimated GFR. The calculation and the inclusion of estimated GFR is problematic because it includes ethnicity and albumin. This leads to underestimation of renal dysfunction and disease severity in Black patients, and that has been well documented in the scientific community. The MELD Plus score was developed using the MELD Plus score was developed using patients with cirrhosis-related admissions. And they looked at 30,000 patients who received care at 2 hospitals in Boston between 1992 and 2010. They have isolated variables that they claim to predict or better predict 90-day mortality compared to the MELD sodium score. However, the limitation of this particular model is that it's only applicable to patients after a hospitalization. All right. And then finally, the MELD 3.0 developed by Dr. Kim and colleague. This looked at liver-only adults on the transplant list from January 2016 to December 2018. They have added the female sex, albumin, and lowered the serum creatinine cap to 3. They also balanced interactions between albumin, creatinine, and between bilirubin and sodium. So this, like my colleague have said, led to a reclassification of 9% of patients who died while waiting on the transplant list and reduced at least 20 waitlist deaths per year. Unfortunately, this study did not report how accurate the risks are estimated or how the models were calibrated. This is concerning because a badly calibrated model can still have a high concordance score.
This is the timekeeper. Time has expired.
As I said, I told you about the hook. I guess people could read your conclusion slide before you stop sharing, but I warned you and it came. So now we have the Rebuttals. So we're ready to do the rebutting. We're going to start with Dr. Maida from Aurora Healthcare, who will rebut the Einstein Healthcare position. Go to it.
Good evening, everyone. I'm Jael Mehta. My partner Ritu Mehta has made it abundantly clear why it is time for MELD sodium scoring system to be retired for organ allocation. The overall transition in patient demographics over the years, the gender disparity, and the lack of incorporation of portal hypertensive complications is something that is clearly backed by both historic and emerging data. I would now like to address Einstein Health's view that MELD sodium is still an adequate method for organ allocation. The first point that they made is that the high accuracy in predicting the 3-month mortality is there for the MELD sodium score. However, as previous data backs the declining C statistic of MELD and MELD sodium with 90-day mortality seen in prior studies in concordance with the decreasing prevalence of HCV-related diagnosis and increasing concordance of NASH-related cirrhosis and alcoholic liver disease, clearly identifies that the studies that were done were over 2 decades ago, and the epidemiology has clearly changed. In addition, they do mention that the modification will not address sex disparity in MELD 3.0 and other studies that were mentioned. However, I'd like to go a little bit deeper into detail about the gender disparity that is present in MELD sodium. As a reflection of lower muscle mass, women's creatinine is consistently found to have been lower than that of men at all ranges of measured GFR. Accordingly, the number of MELD points derived from serum creatinine in women has been shown to be much lower than that of men with similar GFR. Additionally, women start accruing creatinine-derived MELD points at a later stage of renal dysfunction than men do. With these findings, alternate methods have been studied in relation to the gender disparity. According to one of the methods that was discussed by our opponents, the MELD 3.0 article published in Gastroenterology by Kim et al. Does report that MELD 3.0 affords more accurate mortality prediction in general than MELD sodium and addresses the determinants of waitlist outcomes, including sex disparity. It is a better option for evaluation of organ allocation in the current day and age. When looking further at the MELD 3.0 score, the C statistic of 90-day mortality of MELD 3.0 was clearly better than that of MELD sodium, with a C statistic of 0.8693 as opposed to 0.8622. Although the numerical difference appears modest, the difference was statistically significant. And when looking closer at who exactly benefits with the MELD 3.0, one of the subpopulations that was identified to have benefited is females. There were more women that were up-categorized with the MELD 3.0 in general than down-categorized. And out of the 221 female that were noted, a net of 15% were more correctly reclassified. So it is important to note that there are alternate methods that would appropriately be up-classified as they should be. Additionally, the challenges in the current system with standardization of MELD sodium exception points should not go unnoticed. Under the exception points allocated through the use of Milan criteria, there are several issues that cannot go ignored. Several studies have come out noting that the current policy, even after multiple changes, over-prioritizes patients with HCC, with significantly higher transplantation rates with correspondingly lower waitlist mortality rates in comparison with their non-exception waitlist counterparts. Some of these studies include Goldberg et al. From 2012, Bitterman et al. In 2012, and Goldberg et al. In 2012 as well. The risk of tumor progression is not uniform in these groups, and this is something that is not accounted for in the patients. The other undetermined point regarding exception points to the most standardized exception category is the Milan criteria, and this is not something that's studied well as well. There's quite a few other discussion points that were mentioned by our colleagues, but in conclusion, it's undeniable that the progression of the organ allocation system is one that has been backed by data. It's something that's progressed over time based on the data that has been emerging. And it is rooted in medical research. In its essence, it is the ability to adapt to the changing times, and the development in new literature points in every which way that a new allocation system is not only overdue, but necessary. The disadvantages of the current system are far too great, and the data in support of a different allocation system is far too compelling to not progress towards a more equitable allocation system. Thank you.
That was great. Sorry if I mispronounced your name at the beginning. Trust me, you may think it's easy when your name is Robert Brown, but people do ask me whether there's an E on the end, despite the fact I've never met anyone who has an E on the end. And I say, like the color, and they still say, with an E? I was like, I don't know where Brown E comes from, but so it is. But I'll probably get the next speaker right. Dr. Kathy Williams from Einstein Healthcare, who will now rebut Aurora Healthcare's position. Kathy?
Thank you very much sorry, we're just gonna put up our sound. Okay. Thank you to our colleagues. Thank you to the ALF for inviting me and my colleague, Dr. Yan, to participate in this debate. Our colleagues at Aurora Health brought up quite a few interesting points, but we on the composition would like to rebut them, starting with the fact that reminding everyone participating in the debate, the question that was posed to both of us. The question that we were posed and that we were asked to answer was whether the MELD sodium score should be modified. We in the composition are of the belief that the MELD sodium score should not be modified. Our colleagues at Aurora Health raised some valid points or some interesting points about whether the MELD sodium should be used for organ allocation, and we would just like to remind them that that was actually outside of the scope of the question that we're asked and not the question that we on the composition are going to answer this evening. With regard to whether the MELD sodium score should be modified, we don't believe that it should. We think that, as my colleague Dr. Yan pointed out, that the MELD sodium remains a valid tool. There are studies done by Gottfried et al. Who show that despite the belief that the fact that there are some studies that show that there is a decline in the overall concordance score of MELD from the Gottfried et al. Paper shows that the concordance score still remains at 0.72, showing that it is a valid model. Interestingly enough, with regard to that data, when Gottfried et al. Looked at that data and showed that there's a declining rate of a C statistic or concordance score when looking at the MELD data, Dr. Kim et al. And the same Dr. Kim who developed MELD sodium and who developed the MELD 3.0 model, relooked at that data using a different model and found that it did actually remain valid. So we would say that before anyone jumps to using a new model or saying that the MELD sodium score needs to be modified, we'd reiterate the fact that any model that is used really needs to be looked at carefully and closely and examined not in just one data set or with one statistical model, but with others. Moving on to the sex disparities point that our colleagues brought up, they mentioned the fact that there's a gender disparity issue, and we'd like to remind them that it's actually not a gender disparity because gender is fluid, but a sex disparity, namely that the sex that you're born with, if in my case, for example, I'm a woman, I was born a woman, that does result in the fact that because of my decreased muscle mass, I have a decreased, I have an underestimation of my creatinine and the effects of it's on my renal system than my colleague Dr. Yan does. That leads us to that effect on organ allocation, because really what Locke et al. Said, as our colleagues brought up in the proposition, in that paper, Dr. Locke mentioned the fact that there is a sex disparity that is involved in the liver transplant process, but really it's not a fault of the MELD sodium or MELD 3.0 or any of these newer models that are proposed, because in fact they all contain MELD sodium, or they all contain sodium and other objective factors but the fact that there is an organ size mismatch. So as a woman, the average sized woman just has a smaller abdominal cavity. And as a result, even if she were to be at the top of the liver transplant list and have a liver available to her, whether it's through the MELD 3.0 system that would perhaps put her closer to the top, she may not have the ability to find an organ that fits into her abdominal cavity. Moving on to the MELD 3.0 system, one that has been looked at recently, and as our colleague said, it has been published most recently in Gastro in December, published by Dr. Kim, who in fact was the developer of MELD sodium. One of the things that they failed to mention with the change in the addition of sex to the MELD calculation process, by giving women the 1.3 points that they get in the MELD sodium or the MELD 3.0 model, there's a risk of something called stage migration bias. So you take a woman who perhaps has a MELD sodium of 29, and through the MELD 3.0 system, you add those 1.3 points and you push her into a higher strata. So a different category, she would now be in the MELD 30 and up category. With that, she may have a better outcome because of the lack of complications or how well compensated her disease is.
This is the timekeeper. Time has expired.
All right. Two excellent rebuttals. Let's have our judges and the rest of our debaters rejoin us on the stage with their cameras on, and we will start our Q&A. Dr. Gunn, do you want to kick us off again?
This is, I find, a very challenging topic, and I really commend both teams for tackling that very well. So Dr. Mehta and Mehta, if you feel that there are disparities, especially with regard to sex with the MELD sodium, what would you propose as a better tool? I know you mentioned a lot about MELD 3.0. Is that what you would use, and why?
Yeah, I can answer that. So when it comes to, when looking in, to clarify, it is correct. It should be sex disparity, not gender disparity, as we are talking about, sex at this point. When it comes to a model that works with this better, the best one that's been proposed at this time is the MELD 3.0. This is an ever-changing system that we're looking at. There's always room for improvement, but with the MELD 3.0, it does take into effect the sex disparity. Yes, it does. There is an impact of abdominal cavity in terms of receiving livers or having higher or being able to get more transplant. But the big picture is that the creatinine is really the big issue in the disparity, and that is accounted for, and it's reduced in the sense of the MELD 3.0. It does address this issue. The GFR in women with the serum creatinine, it does overestimate the GFR in women, and that is due to a difference in muscle mass. So that is something that is a sex difference that does create that disparity in the score and does give women more of a disadvantage when it comes to having a MELD sodium score.
Another thing to keep in mind, I'd just like to add too, is outside of just the creatinine alone, the lower muscle mass does lead to the serum creatinine being underestimated. But in addition to that, the MELD sodium also ends up exacerbating this disparity, most likely because there's higher volume by total body water in men, leading to an overall decreased serum sodium. And this is something that the relationship is looked at with some of the newer models, such as the MELD 3.0, once again, kind of closing that disparity that is present with the sex.
Thank you for that answer. And I did want to ask a question of the other team, Dr. Yen and Williams at Einstein. What limitations do you think the MELD sodium actually has? And how do you feel about the manipulative possibilities in that scoring system? You have the sodium that can be manipulated with medication. You have the INR that can be manipulated with medication as well. I just want to know if you feel strongly about any limitations in that scoring system. I know you feel strongly about it being here to stay, but do you have any points to make there?
Hi, Dr. Gunn. Thank you for that question. So it is an interesting point, and it's certainly something that we considered. One of the things that we would say is that all of the models that are proposed have that issue because of the beauty of the MELD sodium is that it really relies on objective data. So whether it's the MELD 3.0, MELD GRAIL, all of these have this objective data, and there is that risk of manipulation. We would hope that as physicians who've all taken the Hippocratic oath that we would abide by doing what's best for our patients and first doing no harm, so that we wouldn't do that. But I think it's hard to say, knowing just the nature of cirrhosis and these patients who need these medications and may have a MELD score that changes, it's hard to find a way to get away from that.
And sort of just add to that, you know, in the MELD sodium score, so albumin is not part of the equation. And I think adding that particular parameter into the other score system may actually have a detrimental effect to our patients. It may actually cause physicians to perhaps withhold infusion of albumin in the fear of driving that particular value up. And I think that withholding, you know, albumin infusion for someone, let's say, coming in with HRS would be definitely of a detriment to the patient.
Thank you.
All right, who wants to go next? Maya, you want to go in the same order?
Sure, absolutely. So my question is for the Einstein group. So there's no denying that contemporary causes of liver disease are very different from 20 years ago when the MELD sodium was implemented. And there's a whole lot of reasons mortality has been reduced while patients wait on the liver transplant list. A strong reason is we have great antiviral treatments now. And there's also no denying the fact that women are more likely to die while waiting for an organ compared to men. And third, the natural history pathophys of these contemporary liver diseases, NASH and alcohol, are different from viral hepatitis. So given all of that, I mean, perhaps you don't like some of the alternative MELD sodium scores, but do you think that we need to, and there's also no denying that sex impacts creatinine. So do you think there needs to be any kind of correction made to the way we allocate organs based on everything we know about the changing face of liver disease, women being hit harder by some of these diseases, and they're more likely to not get an organ and die while on the waiting list?
So I'll start by addressing, so of course, the sex disparity and how women are experiencing a higher mortality while on the wait list. So I think my main point is that there are several factors that come into play for sure. So the overestimation of renal function, that is one of three things that studies have pointed out. It does not have as strong an association to sort of the worst outcomes that we're seeing compared to the size mismatch. So, and actually the third one is more the geographical disparity in which the Share 35 policy has been able to address. So for me, again, I don't think that the MELD sodium ability to capture disease severity is sort of at fault here. You know, there should be a policy implemented, perhaps similar to the Share 35, but more so with respect to body size. Perhaps there needs to be prioritization of women of smaller body stature when it comes to liver allocation.
Yeah, I think just to follow up on David's point, we would just add the fact that changing MELD sodium to whichever model it is won't completely fix the issue that is related to the availability of, or the lack of organs that fit into women's abdominal cavities. So we would suggest that perhaps there needs, before we change to a new model, we need to develop a simultaneous system to make sure that there are two systems going on to make sure that women are prioritized, but then also have access to livers that will fit into their bodies.
And just to round up with regards to sort of the changing etiology of liver disease, how we have shifted from viral hepatitis to, more alcohol-related liver disease and NASH. The current system, we're not prioritizing those with viral hepatitis. The patients with alcoholic liver disease and alcoholic hepatitis are receiving high scores, and they are being transplanted under the current system. So I don't necessarily see how, because of sort of the population or the etiology of liver disease has changed, that certain populations are not being prioritized. I don't see the NASH patients or the patients with alcoholic liver disease being left behind, and other etiologies being favored in the current system. So I still think it's valid.
Right. Yeah, I think the point I was raising is that women are more likely to be affected by liver disease now as opposed to 20 years ago. And my question for the Aurora group is, your argument entirely boils down to sex differences in creatinine. Do you think that explains the disparities we're seeing on the wait list?
I think that the sex disparity is actually multifactorial. Yes, creatinine is probably the largest contributor to this disparity. However, the MELD sodium also puts men at a higher advantage given their total body water in relation to their total body weight, giving them an overall lower sodium. So there's a multifactorial component. Of course, the abdominal cavity size is a factor, which is something that needs to be looked at further in terms of how we can find a more equitable system. However, there's multiple flawed kind of parts within the MELD sodium itself that I think would be addressed with a more equitable allocation system.
Thank you.
Thank you.
All right. Okay. Let me, the great debates, I think the topic was definitely very difficult. Let me ask you a little different question here. When MELD was used as an organ allocation, implemented as an organ allocation system, they put a cap on it, a 40 MELD. MELD 40, we cannot list anybody who has more than MELD 40 on the list. Should that cap at least be changed or moved or eliminated? Both teams, we can make an argument, because it was done because I think to compensate for the futility of transplant with very high MELD score. So in those regions where getting a transplant is very difficult, there's much more competitive or shortage of organ allocation. Could that cap be removed?
Yeah, so I just like to mention that it's been well studied and well documented that patients with MELD of greater than 40 do experience a greater waitlist mortality compared with those of MELD of 40 or lower. And so, having it capped at 40 certainly plays a factor in creating an additional layer of disadvantage for those patients. So newer models, whatever it may be, do look at not having a maximum score of 40 and not capping it and causing those patients to not be further disadvantaged. So I think this is an additional great point that you bring up.
All right, I think, oh, did you have a question for the other side? Sorry about that.
No, that question was for both teams.
Yeah, so I think our stance, I would say with the shift in the etiology of liver disease, we see more and more alcohol related liver disease, and these patients do have incredibly high MELD scores. I do think that by capping the MELD score sort of evens out the playing field a little bit for the patients with the other etiology of liver disease. We don't yet have enough data to support transplanting alcoholic liver disease patients with incredibly high MELD. So at this point, I don't think that it would benefit sort of the entire population.
All right. Nobody mentioned the discrimination against men of small stature, and us short dudes I would have given points to someone who had mentioned that, want to take care of us, but fortunately I'm not one of the judges. So we will wait and see what our judges determine for debate number 2. And we're going to move into the final debate of our evening. Debate number 3, our first associates debate. This is the key clinical question for this one is whether or not dual immunosuppression long-term should be used for all patients with autoimmune liver diseases. As a reminder, pro is 8, con is 8, rebuttals 5 minutes each. You've seen that the timekeeper is serious, so we'll try to keep the time. This is Northwestern Medicine, taking the pro side, the University of Illinois, Chicago, 2 veterans of our debates from the Chicago MAC who will go at it in our last debate. So let's introduce the debate teams. Next slide. Presenting our pro position that dual immunosuppression should be used long-term is our team from Northwestern. They're so good they don't even need a mentor. We have Hazel Domingo and Lauren Lippes. Hopefully I'm close to correct. Then we have the con side, the University of Illinois at Chicago. Also so smart, they don't need a mentor. They are going to say that dual immunosuppression should not be used long-term for all patients with autoimmune liver disease. Those debaters are Dana Pierce, PharmD, and Kristen Hiegler, also a PharmD. We're going to start with the pro position. And I believe Lauren is starting off the debate. Esteemed timekeeper, let's go into our final debate. Lauren, you look, oh, there you go. There you go. Now you look normal. All right, let's go. I'd turn off that virtual background. Makes you purple.
Okay, we're good now. All right, I'm going to share my screen. Okay, we're going to get started. My name is Lauren Lipes. I'm a nurse practitioner at Northwestern Hospital with transplant surgery. And Hazel and I are really excited to be here for the American Liver Foundation academic debate. So our topic, as mentioned, is dual immunosuppression long-term should be used for all patients with autoimmune liver disease. So progressive autoimmune liver disease is progressive immune-mediated inflammation that can cause destruction of the hepatocytes and biliary epithelial cells. If untreated, it could lead to irreversible liver damage requiring transplant. Autoimmune liver disease can be composed into 3 different types. Autoimmune hepatitis is characterized as injury to the hepatocytes. Primary biliary cholangitis is characterized as injury to the intrahepatic bile ducts. And primary sclerosing cholangitis is hallmarked as inflammation and scarring of the intra and extrahepatic bile ducts. Autoimmune liver disease accounts for 23% of liver transplants, and the 5-year survival rate is 70 to 80%. So why is dual immunosuppression important for this population? Patients transplanted for autoimmune liver disease are at greater risk for rejection and disease recurrence when compared to other liver diseases. And this is why immunosuppression is really important to prevent both of these from occurring. With disease recurrence, you can see for all 3 autoimmune liver diseases, they are pretty significant. And the percentage increases with the age of the graft. As you can see here, for PBC in general, it's 43% at 15 years. For PSC, for patients that develop recurrence, 20 to 43% will require retransplantation, which is pretty significant. The risk for rejection, autoimmune liver diseases have an increased risk for late acute rejection when compared to other liver diseases. This study was late rejection after liver transplant and how it impacts survival, and late rejection was considered greater than 6 months. And it did show that for the 3 autoimmune liver diseases that they had an increased risk compared to other liver diseases. So when talking about immunosuppression, the discovery of effective immunosuppressive medication, primarily cyclosporin in the early 80s, was the turning point that dramatically improved patient and graft survival after liver transplant. Over the last few decades, immunosuppression has progressed, leading to a significant decrease in acute cellular rejection and improving graft and patient survival. Unfortunately, long-term exposure to immunosuppressive medications and their adverse effects contribute to mortality and morbidity in the long-term effects of liver transplant patients. Adequate immunosuppression is a balancing act to prevent allorecognition and rejection while avoiding over-immunosuppression and its long-term consequences. So as you can see here, there are many side effects for each immunosuppressive agent, and the goal of treatment is to minimize the adverse effects and optimize graft function. The OPTN and SRTR 2020 annual data report of the liver, which was about 20 days ago that it came out, showed that 71% of liver transplant centers use triple therapy at the time of transplant. This is for all livers, not specific to autoimmune liver diseases, and it does show that different centers have different regimens. Patients do not need triple therapy long-term, and weaning off triple therapy is recommended given the increased risk of side effects long-term. The 2018 International Liver Transplant Society Consensus Guideline showed that patients at higher risk, higher immunologic risk, which was PSC, PBC, and autoimmune hepatitis, should be considered for dual therapy with a combination of 2 of the following: calcineurin inhibitor, mycophenolate, and everolimus. Steroids are not included in this recommendation. The use of steroids have been controversial, especially with autoimmune liver diseases, particularly autoimmune hepatitis. So if we're on dual therapy, are we okay to be off steroids? Weaning patients off steroids would be beneficial given the risk of hypertension, hyperglycemia, metabolic disease, bone disease, as you can see here as the recommendations. There was a meta-analysis published in 2018 that showed that compared to continuation, steroid withdrawal did not increase disease recurrence after liver transplantation. The ILTS 2018 guidelines also recommend that by 3 months after liver transplantation, most patients should be weaned off steroids. In patients with higher immunologic risk, consideration should be to either maintain low-dose steroids long-term or add an anti-metabolite to facilitate steroid weaning. The AAA SLD 2019 guidelines also recommend gradual discontinuation of steroids post-liver transplant due to limited data. What about CNIs? The most common side effect of is nephrotoxicity, primarily tacrolimus, which is why renal sparing protocols have been implemented to minimize the effect of tacrolimus. Combination of mycophenolate and tacrolimus allow for a lower tacrolimus trough level, which decreases the adverse effects. This 2003 study evaluated the incidence of chronic renal failure in recipients compared or on non-renal transplants. Liver transplant patients had the highest risk or incidence of chronic kidney disease over 10 years. The risk of chronic renal failure increases over time among patients in all of the categories that we see here, which is why it's important to renally protect patients not only early after transplant, but long-term. Patients with chronic kidney disease also have high risk for cardiovascular disease, which is the leading cause of death in the United States. The ILTS 2018 guidelines also recommend early institution of everolimus in combination with low-dose tacrolimus, resulting in significantly better renal function than is achieved with standard dosing of tacrolimus. So as we can see, we can wean off steroids and we can wean off calcineurin inhibitors and still have adequate immunosuppression. What about monotherapy? Monotherapy has a high dose of a single medication that leads to significant adverse effects. Complete weaning of CNIs to everolimus alone has shown to expose patients to an increased risk of rejection and occurrence. A 2019 study examined the use of everolimus monotherapy and had to be terminated due to the increased risk of rejection by 20%. What about triple therapy? Oversuppressing the immune system increases patients' risk for infection and malignancies. This 2020 study analyzed long-term patient and graft survival after liver transplantation and showed that infection and neoplasia were the leading cause of death after a liver transplant for all groups. Do we want to over-immunosuppress these patients? I don't think so. What about the cost? For triple therapy, can patients afford triple therapy? In monotherapy, if they get rejection, can they afford biopsies, treatment for rejection, frequent follow-ups? I don't think so. Cost for liver transplant, $800,000. If they have to get retransplanted, can they actually afford that? Will their insurance cover that? What about the loss of wages for the patient and the caregivers? What about emotional, psychological burden? So for a conclusion for us, dual therapy maximizes the effectiveness and minimizes adverse effects of immunosuppression for autoimmune liver diseases. When compared to mono and triple therapies, dual therapy has a lower risk for infection, malignancies, rejection, and disease recurrence. Dual immunosuppression should be used long-term for all autoimmune liver diseases due to the disease recurrence increasing with time after transplant. Would you want to risk rejection or disease recurrence? Do you want to prescribe unnecessary medication?
This is the timekeeper. Time has expired.
That was great. Thank you. You made it just basically right under the time point. So that was great. Now we'll have Dana Pierce from the University of Illinois at Chicago, who will provide the con position. Dual immunosuppression should not be used for all patients with autoimmune liver disease. Timekeeper ready? Let's go. Unmute, Dana.
Hi, everyone. Thanks for joining us today. My name is Dana Pierce, and today Kristen and I will be discussing why dual immunosuppression long-term should not be used for all patients with autoimmune liver disease. And for this topic, I'll be breaking it down into these two separate buckets, pre-transplant setting and the post-transplant setting. Starting off with the pre-transplant setting, I'll be highlighting this article from the New England Journal of Medicine by Johnson and colleagues, which was a prospective single-center trial that included 72 patients with autoimmune hepatitis who were in remission and tapered off of prednisone and maintained on a higher dose of azathioprine. And 83% of these patients were able to remain in remission, which is demonstrated in this Kaplan-Meier curve on the slide. And they had a long follow-up duration of over 5 years on average, and even up to 10 years in some patients. These patients all had their side effects mitigated following discontinuation of steroid therapy, including resolution of Cushingoid bases, and 44% of patients had a weight loss. So based on this data, dual immunosuppression is not necessary for all patients with autoimmune liver disease in the pre-transplant setting. Now shifting gears to the post-transplant setting, our patients with autoimmune hepatitis are known to do much worse than those with other etiologies. There's only an 82% rate of 1-year allograft survival in patients with autoimmune hepatitis. So that means 2 out of every 10 patients with autoimmune etiology is going to have their allograft fail after only 1 year. And these Kaplan-Meier curves from an article by Lee and colleagues show us graphically how high this rate really is. So the figure on the left represents the incidence of death post-transplant, with almost 20% of patients dying by 5 years post-transplant and over 30% dying after 10 years. This figure on the right represents the incidence of patients being retransplanted. And as you can see, the patients with autoimmune hepatitis have a lower rate, but the reason for this is because the rate of death is so high that they weren't even able to make it to the point of retransplant in order to potentially prolong survival. So based on these numbers, we really need to be doing more for these patients to further prevent allograft failure and death. A large reason why these allografts fail so frequently is due to the high rate of disease recurrence. The recurrence rates of autoimmune hepatitis can range somewhere between 10 to 40%, but based on a meta-analysis comprised of 90 different articles, it's thought to be about 22%, which is significantly higher than other etiologies. And there's several different risk factors that are known to increase the risk of autoimmune hepatitis, and we can separate these out into preventable and non-preventable risk factors. Rejection and steroid discontinuation, for sure preventable. Patients with rejection are more likely to have disease recurrence. So what's one way we can prevent rejection and disease recurrence? By keeping them on triple immunosuppression and not withdrawing the steroids. These other risk factors, they're not going to be preventable, but even if you do plan to use dual immunosuppression in some of your patients, these risk factors can be utilized to identify patients who would benefit from triple immunosuppression, as opposed to using dual immunosuppression in all patients, as the prompt suggests. I won't go into too much detail about the immunology. However, it's important to discuss these processes in order to fully understand why it's so important to use triple immunosuppression in these patients from a mechanistic standpoint. In autoimmune hepatitis, we see both effector T cells and regulatory T cells recruited to cause apoptosis of the hepatocytes. And in addition to the T cell involvement, we're also seeing an increase in the amount of B cells that are recruited to the liver. So we really need to maintain our patients on an anti-metabolite, since this is going to be the only maintenance immunosuppression that actively suppresses both T and B cells. Kustanen and colleagues also found that an increase in immunosuppression regimen without an anti-metabolite is going to increase the risk of recurrence by about 1.5 times. Similarly, we need to continue these patients on steroids in order to inhibit the cytokines involved in T cell proliferation. And Milkowitz and colleagues found that over a quarter of patients who had steroids withdrawn had recurrence of disease of 23%, and 23% of these patients, 27%, and 23% of these patients required retransplant. Whereas Krishnamurthy and colleagues found that patients who were maintained on triple immunosuppression only had a recurrence rate of 6% at 5 years post-transplant. And this article was a single center retrospective chart review, including 73 patients with autoimmune hepatitis who underwent transplant, and they demonstrated a very low rate of remission of only 6% at 5 years and 10% at 10 years post-transplant. If you look at the Kaplan-Meier curve on the right, you can clearly see that the majority of these patients' allografts are lasting up to 15 years post-transplant. However, if we're talking about being maintained on more medications, then of course we have to be talking about the medication side effects as well. And I would argue that if we maintain our patients on triple immunosuppression, then we can actually get away with less toxicities. And similar to my colleague who also mentioned this Ojo study, I'm also going to be going into why utilizing triple immunosuppression can reduce our tacrolimus goals, our CNI goals, in order to prevent chronic renal failure over time. So this study, as she mentioned, demonstrated the high incidence of chronic renal failure. And as you can see, liver transplant patients have one of the highest incidence of chronic renal failure post-transplant. And we know that this is due to the calcineurin inhibitors. So if we maintain these patients on triple immunosuppression, we can lower their CNI goals and potentially prevent this CNI nephrotoxicity that's going to be inevitable. We're also well aware that the prolonged steroid use leads to an increased risk of cardiovascular disease, but this is a dose-dependent effect. And the overall incidence of cardiovascular disease decreased by 9% with prednisone 5 milligrams daily versus 10 milligrams daily. So if we maintain our patients on triple immunosuppression, then we can lower their prednisone dose to minimize the side effects. And overall, we need to be thinking about the risks versus benefits of keeping these patients on steroids versus steroid withdrawal. Yes, maintenance steroids, we have increased risk of osteoporosis and cardiovascular risks, but we have medications we can use to mitigate these in order to prolong overall survival. However, if patients have disease recurrence and end up losing their allografts, then they're going to have a much higher mortality rate. And at the end of the day, you can live with diabetes, you can live with osteoporosis, but you can't live without a liver. So just to summarize, autoimmune liver disease has a higher rate of recurrence and allograft failure, and we can use triple immunosuppression to reduce the risk of recurrence. And we can also use triple immunosuppression to reduce toxicities by lowering all of our immunosuppression doses. And just in general, dual immunosuppression should not be used in all patients with autoimmune liver disease, because we can't necessarily put our patients in a specific category. Different patients, we're going to have to specialize and change how we practice and change our approach based on each patient who kind of presents to us. And I'd like to thank the American Liver Foundation for having us and for hosting this inaugural AMAC series in the debates. And I'd also like to thank a few of our colleagues at UIC, Dr. Maya Campara, Benito Valdepenas, and Dr. Adam Mikolajczyk.
Well, I had wondered, and so had Purple, my cat, whether we were going to do pre or post. It's interesting that our associates have taken different approaches to the same question, which make the rebuttal and the Q&A even more fascinating. So let's start the rebuttal. We're going to start with Hazel Domingo from Northwestern, who will rebut the UIC position.
Good evening, everyone, and thank you for staying for us. I would like to start by saying that they mentioned the 5-year survival in patients with autoimmune hepatitis is 70 to 80%. That's not lower than the average survival based on the SRTR data that came out in 2020 compared to other reasons for liver transplant. So it's not actually lower based on what we know. Due to the increased efficacy of immunosuppressive regimens, 1-year survival has improved significantly. But today we're talking about long-term immunosuppression, that is immunosuppression beyond the first year. A retrospective long-term survival analysis by Rana et al. Of over 111,000 patients who underwent liver transplant between 1987 and 2016 showed that despite profound improvements in 1-year survival, there has been no significant improvements in survival beyond the first year. These findings are consistent in the US experience derived from the SRTR data, the UK experience, the European Liver Transplant Registry, Nordic Liver Transplant Registry, as well as in pediatric liver transplant recipients. Despite functioning livers, transplant recipients have 21% lower survival compared with the general population, in large part due to the infection and malignancy. They have over 75 times greater risk of dying from malignancy and 5 times greater risk of dying from infection. Cardiovascular disease is also a leading cause of morbidity and mortality, and the 10-year probability of coronary heart disease is higher in liver transplant recipients than the general population. Development of de novo malignancies, cardiovascular diseases, and recurrence of the primary disease. These are the reasons for poor outcome in the long-term course. And we know immunosuppression is considered the most important risk factor in post-transplant cancer development. In our efforts to protect patients from rejection, we tend to over-immunosuppress. Immunosuppression minimization should be considered and trialed, even in patients who have high immunological risk. This has been established in national and international guidelines. So why not monotherapy? Well, autoimmune liver disease is a whole body systemic issue. They get a new liver, but they do not get a new immune system. Further, renal dysfunction is a major late complication after liver transplant and is associated with poor survival, even after adjusting for confounding risk factors. And since CNIs are known to cause or at least worsen nephrotoxicity, reduction of CNI and introduction of mycophenolate or an antimetabolite became the cornerstone of immunosuppression. What about triple immunosuppression? Well, obviously it works. It's great at preventing rejection. There's no doubt about that. But at what cost? Development of de novo malignancies, cardiovascular disease, infections. The question then is the treatment perhaps worse than the disease itself? Is this the cost of being alive, to have cancer, to have a heart attack? Both the ILTS and AASLD suggest gradual glucocorticoid withdrawal in patients at higher immunological risk. That is like patients with immune-mediated diseases, and adding azathioprine or mycophenolate to facilitate steroid weaning. And in addition, there's also been studies showing that the combination of mycophenolate and everolimus or other mTOR inhibitors can also work. There's no good data that triple immunosuppression extends life or increases the quality of life. It's just what we've been doing for a long time, and people are afraid to try something different. Long-term outcomes data show that we might be over-immunosuppressing our post-liver transplant patients. This is our wake-up call. I believe that there's multiple papers. There's a 2017 paper from Tennessee, a single transplant center study of patients with autoimmune liver disease, including PSC, PBC, and autoimmune hepatitis, showing that MMF and TAC or mTOR indefinitely, 3-year survival, 90.4%, 5-year survival, 82.2%, 7-year survival, 75%. There's another paper from Berlin from 2005. They show that there's no difference between TAC and PRED or TAC and MMF. There's another paper by Assad Munis studying liver transplant recipients from 2006 to 2013. Again, TAC and MMF works for patients with autoimmune liver disease. So I believe our opposing team made very good points, but I'm afraid we have to disagree. Dual immunosuppression is superior to the alternatives and should be the way to go long-term for patients with autoimmune liver disease. Thank you.
Well, thank you. This is really turning out to be a spirited associates debate. I'd be afraid if I was the MDs that one day they're going to pit the associates against the MDs and you guys are going to kick some tail. So our final speaker before we get into our final Q&A, Kristen from Hiegler from the University of Illinois, who will rebut Northwestern's position. Timer ready, and here you go.
Hi, everyone. I would like to start by thanking the American Liver Foundation for hosting this debate tonight. Our colleagues at Northwestern presented compelling evidence and guideline recommendations to show that steroid withdrawal can be safe and successful after liver transplant. The caveat here is the use of phrases like most patients and should be considered. While dual therapy may be great and reduce adverse effects in most patients, our prompt specifically questions if this is appropriate in all patients. The primary literature assessing optimal immunosuppression in this patient population is limited by retrospective data, small sample sizes, and lack of comparator groups. Additionally, most studies assessed outcomes based on immunosuppression type rather than the number of agents used and did not specify differences in outcomes based on this. There is a high variation in reported outcomes between studies due to changes in surgical techniques, variable follow-up periods, advancements in technology, and the use of for-cause versus protocol biopsies. Currently, there are no prospective randomized trials directly comparing outcomes between dual and triple therapy. Thus, the available evidence does not support the use of dual immunosuppression for all patients with autoimmune liver diseases. What we do know and what has been consistently demonstrated in the liver in the literature is that patients with autoimmune diseases after liver transplant are at an increased risk for rejection and recurrent disease, as my colleague Dr. Pierce highlighted. A recent study from Satapathy and colleagues in 2017 found a 30% incidence of biopsy-proven rejection in 74 patients with autoimmune hepatitis after liver transplant on dual immunosuppression without steroids. This rate is very high given that this is after induction with thymoglobulin. While rejection may be treated and may not have always significantly impact the long-term outcomes, for autoimmune hepatitis patients specifically, rejection further increases the risk of recurrent disease, which is not benign. The rate of graft loss after disease recurrence is high, reported in 20 to 50% of patients with recurrent autoimmune hepatitis. Thus, this patient population may not be appropriate for dual therapy. We cannot refute the metabolic and cardiovascular associated risks with maintenance steroids. However, we do know that the risk of cardiovascular disease is highest with long-standing uncontrolled diabetes and hypertension. In the transplant population, our advantage here is that we are aware of this risk up front, and with vigilant monitoring and early intervention, we can better control hypertension and diabetes to avoid poor cardiovascular outcomes. Additionally, we now have medications in our toolbox such as SGLT2s and GLP-1s, which have demonstrated cardiovascular benefit. I would argue that the risk of rejection, disease recurrence, and graft loss poses a greater risk to autoimmune hepatitis patients after transplant than the risk of cardiovascular disease. Thus, dual immunosuppression may not be ideal for all patients after transplant. While steroid withdrawal may be an appropriate approach in certain patients in this population, it is also often unsuccessful. In 1999, Milkowicz and colleagues reported that 67% of patients with autoimmune hepatitis required steroid reinitiation. And similarly, in a study from 2008, Campson and colleagues reported only a 50% success rate of steroid weaning in patients with autoimmune hepatitis. Our Northwestern colleagues also brought up the issue of cost. However, the discussion with dual therapy versus triple therapy also involves stopping the steroid, which we know is dirt cheap. The steroid withdrawal is not going to significantly lower the overall monthly price of medication for patients. They also highlighted the high cost of biopsy, rejection, treatment, and retransplant, which I would argue would have a higher risk of that with less and not more immunosuppression. While I agree with our colleagues from Northwestern that steroid minimization and reducing the risk of cardiovascular events is an important concern, there is simply not sufficient evidence to support the use of dual immunosuppression for all patients. We agree that steroid withdrawal may be beneficial in some patients. However, the evidence we discuss here today clearly describes specific clinical situations where dual therapy is not appropriate. This includes in both the pre-transplant setting where a monotherapy approach may be successful, and with autoimmune hepatitis post-transplant, given the high rate of negative outcomes associated with disease recurrence and the high incidence of steroid initiation. The choice of immunosuppression should always be individualized based on patient-specific factors rather than a one-size-fits-all approach. Thus, in conclusion, dual immunosuppression should not be used for all patients with autoimmune liver diseases.
Well, I'm so honored to be able to witness the first associates or AMAC debate. I can assure you this won't be the last. All four of you did fantastic. Let's bring our judges up and we'll get some questions. Have everybody put their camera on.
Okay.
Dr. Gunn, are you ready for the first? Oh, all right.
Okay, I can start.
First.
Yeah.
Yes. Oh, Dr. Gunn, you're gonna.
No, go ahead, please.
Right, yeah. That's question for the UIC team, who are suggesting triple immunosuppression for all patients after liver transplant for autoimmune hepatitis. One of the component of triple immunosuppressions are antimetabolite. The more common one that we use as an antimetabolite is contraindicated in pregnancy. We are asking them dual contraception, and most of the autoimmune hepatitis patients are female, and after transplant, they do resume their pregnancy potential. So what is the justification of continuing the medication for them and having them to continue dual contraception and not plan a pregnancy?
Yeah, so I think that's a great question. And what I would argue here is that in these scenarios, when we feel strongly about continued need for antimetabolite, we would often switch to azathioprine in the setting of pregnancy. So the evidence that we discussed specifically looking at autoimmune hepatitis and different agents associated with disease recurrence, they look at antimetabolites as a whole. So this is not differentiating between mycophenolate and azathioprine. So while from a rejection standpoint, in the transplant setting, we do typically prefer mycophenolate, azathioprine is an appropriate option here in the setting of pregnancy.
All right. To the Northwestern team, honestly, when I saw the debate topic, I thought the debate would be pros and cons of dual versus monotherapy immunosuppression, not the triple immunosuppression. And I was surprised to hear that triple immunosuppression is suggested and good evidence is offered there. So why not monotherapy? You have given us some input, but why would monotherapy be inferior than dual therapy?
I think monotherapy, this population is different from the rest of liver transplant recipients who we are able to wean off the monotherapy and sometimes even completely off immunosuppression. But the immune system of these patients are not transplanted. And so therefore they're at a higher immunological risk post-transplant. And further, if you put them on monotherapy, they would usually require a higher dose, usually of a CNI. There's some studies out there showing that mycophenolate granulate alone does not work, or everolimus alone does not work and lead to high rejection rates. And so if you put them on a high CNI dose, then you're also putting them at risk for nephrotoxicity, which is just not necessary when you have other good drugs. And also the side effects with these medications are dose dependent over time. And so the theory is if you're able to give them lower doses of both the medications, then the side effects will also hopefully be lower over time.
So I can go next. That was a great debate. Full disclosure, I'm not a transplant hepatologist. I'm a general hepatologist, so I'm speaking from that vantage point. So, I mean, ultimately, the best medication is a medication that a patient takes. Given that, can each team comment on what is known about cost, compliance, patient acceptability, quality of life effects of mono, dual, or triple therapy? I mean, if you have a patient who, prefers, to take fewer drugs, versus a lot, or the cost, what do we know about these issues when it comes to actually taking these meds? And how does that impact your decisions?
I think that's a great point. As you said, they're only going to work if the patient actually takes them. And I think that that's one of the reasons why triple immunosuppression can also be helpful, because if a patient's not taking one of their medications, at least they're still taking two of them. But also just in general, I think that, for our patients who might not necessarily have the best compliance, maybe those patients would be better off with dual immunosuppression. And I'm not arguing that dual immunosuppression doesn't work for some patients. I'm just arguing that for certain, it doesn't work for all patients. There's going to be certain patients who are going to be on dual immunosuppression, they're going to reject, and we're going to need to add on steroids or need to add on a third agent to maintain them overall. So I think in general, yes, compliance is definitely an issue and definitely something that we need to continue to work on, but having more people kind of highlight to the patient how important it is for them to take their medication, proper adherence, proper counseling for these patients, I think that that's something that we can really kind of ensure that they end up taking their medications more regularly.
Hi, in response to your question too, I mean, look, nobody wants to take medication. Patients don't want to take any medications. That would be the best case scenario if it wouldn't cause their liver to reject. But we do a lot of education for patients, pre-transplant, post-transplant. The pharmacists, which I'm sure UIC is aware of, talk to patients after transplant and go through all of their medications with them. And then in follow-up appointments, they have multiple follow-ups, multiple times a week where they go back over medication. So the more medications you add on to that list, there's more risk for confusion, for them having non-compliance. So, triple therapy or quadruple therapy or adding on unnecessary medications can definitely increase the risk of compliance. But dual therapy, as we've shown, has really been the best regimen for patients with autoimmune hepatitis and autoimmune liver diseases in general. But being able to go over the teaching with them, we have social workers that follow them outpatient. They help with cost of medication if needed. And then we have support for them if there's any issues when it comes to overwhelming feelings after transplant. So I think we definitely support our patients, but having too many things at once, I think, would be the biggest contributor to non-compliance and not taking their medication. So triple therapy should not be the way.
All right, Dr. Gunn, last question.
Well, I know that we're running out of time this evening, and I wanted to congratulate both groups for doing a great job. And I just wanted to say, it does seem that we all agree that something needs to be on board, whether it be 2 versus 3. But what about this long-term terminology that both teams used? What is long-term when we're talking about these patients and immunosuppression? And when is that kind of golden time to rethink what we're doing? Both teams, please.
I think that's a great question. And I think that's something that has kind of changed over time because, now with everything, our outcomes after transplant are improving and we're less focusing on, acute risk of rejection and more long-term survival for patients, which is wonderful. So I think A lot of the studies that look at the cardiovascular outcomes do report, up to 10 years of data. So I think from that standpoint, the duration of when we think about the cardiovascular risk is really looking at, like years down the line after transplant, after these patients have been on these medications for a long time. And then when we start thinking of when we can start withdrawing certain medications, so that's really a debatable approach. So some studies look at early steroid withdrawal, in the first couple of months after transplant, while other studies that looked at steroid withdrawal in autoimmune patients waited for patients to be stable without remission for 6 months or for a year. So I don't think that we really have a certain standard or set time point at this time. It really varies when you look at each of the individual studies.
Thank you.
So in preparation for this debate, we went with the ILTS liver transplant immunosuppression consensus from 2018. They don't have a strict definition, but when taking into consideration immunosuppressive medication changes in trials, the immediate post-transplant period or medium term is between 1 to 6 months, and long term it starts after 1 year. And so for the purpose of this debate, long-term immunosuppression is anything beyond the first year. And then, obviously now there's like emerging data of like beyond the first 5 years. As you know, in the SRTR data, usually it cuts off after 5. But I think that since transplant recipients are living longer now, long-term could very well have a new definition in the future.
Thank you.
All right, so all of our debaters, hang on. You're going to be hidden for a while. Our judges are going to go into a secret back room where they're going to debate and fight. And I'm just here to thank and amuse you while they do their deliberation. So first, the people I want to thank are our generous sponsors for their support of this academic debate, particularly our national premier supporters, Abbvie and Eisai. And of course, our deepest gratitude to all of you who've been listening, learning, and enjoying this. As a gentle reminder, there's still time to donate so we can get to our fundraising goal of $5,000 so we can continue to do our work. The link is here on your screen. It's in the Q&A box. Please take a moment. Any amount would be appreciated. And while you're making that donation, and we begin making our closing comments, all of our mentors and debaters can join us for the final comments. I really do want to thank all of our teams for an outstanding job. I think anyone in the audience, I've been getting text messages about how both engaging, informative, and well presented the data was. That's a mark of your skills, the young trainees and our associate members, and their excellent mentorship. I also want to thank the judges for great questions. They kept us, the debaters, on their toes and us engaged. The ALF tech team, this is getting all these people in the right place. No one ended up looking like a dog or having their tech messed up. Thank you. And remember, tonight's not the last night. Debate Madness will continue till Friday when March Madness resumes and UNC crushes Duke for Coach K's final game. Please register for these important programs and promote them to your friends and colleagues. And here are our website information. Please visit the web, like us on Facebook and on Twitter and Instagram. It has much more interesting stuff than 90% of what you waste your time on Facebook and Twitter and Instagram looking at. So as we, as our teams begin and our judges begin to turn on their cameras and join us back on the stage, let's talk about the Liver Life Walk. That's a signature event of the ALF. It allows people with liver disease to come together to raise funds. They join with their team. I can tell you that our team, Team Gratitude, New York Presbyterian, always crushes the New York Walk, and we plan to do so again. We're so happy to be coming back in person for the walk, and it is definitely festive and inspiring. 13 in-person walks and a virtual walk this year. The dates are here. You can go to the website, liverlifewalk.org for more information. But definitely, if you've never done a Liver Life Walk, get out there and do it. And then, if you're really tough, you can do one of the Liver Life challenges. For this one, I just sponsor somebody else. I thought about doing the 5-borough bike tour. I heard it was like a disaster and that I would likely die, so I skipped it. I'm not a great bike rider, and I will never run a marathon. I will watch a marathon, but we have 2 marathons upcoming, Chicago in October, and in the great city of New York, the New York Marathon, the best one after Boston. And of course, there's El Tour de Tucson in the end of November before, well, but when it gets cool enough to run it. And if you want to not run or kill yourself, we have the Legacy Gala. That one I like. The Legacy Gala allows you to sit and eat and drink with your friends, something I'm really good at. And it recognizes individuals who've made an outstanding contribution to host patient families, medical professionals, organizational partners, and business visionaries. The galas, Boston is in May. The New York comes back next October. We had our last Legacy Gala in New York. It was fantastic. First in-person event I've been to in a long time. Very well attended and a wonderful way to both support the ALF and see people who aren't necessarily wearing a mask. Next, obviously ALF Advocacy Day on Capitol Hill. You notice how nice these people are. They're not storming the Capitol. They're coming to the Capitol in peace to raise awareness for the 100 million people with liver disease, volunteers and coalition partners, advocating to our legislators. If you've never done Advocacy Day, it's a great chance to see our nation's capital, meet your representatives, and share important things that can really move the ball forward. It's something I definitely have enjoyed doing when I did it. You can go to liverfoundation.org/advocacy, find the dates and sign on up. And then we can't forget the children. We love the children. And there is a private Facebook support page for biliary atresia family members and patients. It is a moderated group by an ALF staff member and a biliary atresia parent. And this will launch on April 6th. It will provide a peer network, reliable information to families who have children with biliary atresia, and exclusive monthly educational programs on pediatric liver disease that relate to the BA, not the BS, the BA journey, and an opportunity to ask the experts. So share with your patients, or if you are a patient or a family member, you certainly should look to join. It's Life with Biliary Atresia, an American Liver Foundation Facebook support group. I'm sure if you go on Facebook, look for ALF and biliary atresia, you'll find it. Not go to the ALF and they'll help you. So the ALF is also having a rare disease summit on June 22nd and 23rd. We know it's going to be so great that we're calling it the first annual. because we know there'll be a need for a second annual. It will bring together 50 rare liver disease stakeholders, patients, caregivers, hepatologists, primary care providers, patient advocacy personnel, and industry folks for a 4-hour virtual roundtable. You don't have to travel, to identify solutions for improving the health outcomes of individuals with rare liver diseases, which we know usually aren't studied by big pharma. This meeting will focus on answering the following questions. How can people avoid misdiagnosis or achieve earlier diagnosis and connection to care? How can we educate more people about genetic testing and address concerns about stigmatization or even discrimination? How can we reduce the patient burden and improve the overall patient experience? If you want an invitation to join this rare disease summit, you can email Ivory Allison at iallison@liverfoundation.org. So I hope that's things that would interest you, but now here's the moment you've all been waiting for. The virtual cup. Who gets it? Who's gonna get it? And I do know. Here are our winners. The question was, someone asked the question, text box, did Purple get to vote? Purple the cat? Purple the cat had a lot of trouble. She enjoyed all the presentations. She said she was glad she didn't have to vote, as was I, glad I didn't have to vote. It was definitely very close on all three. So let's start. The winner of debate number 1, which pitted the University of Wisconsin against Advocate Lutheran. The winner, Advocate Lutheran. Congratulations. The winner of debate 2, Aurora Healthcare versus the Einstein Healthcare Network. Also very close. I don't know if it was unanimous or not. They didn't tell me. Aurora Healthcare took the debate number 2. Congratulations to the folks from Aurora. And then finally, the winner of debate 3, Northwestern versus UIC. The winner, the folks in purple, Northwestern. But all of you, purple did not get any votes for the best presenter, and neither did I, but that's okay. I really think that everybody did well. I'm glad I didn't have to vote for which was the best of the 3 debates, because they were all really fantastic. We thank you for spending these hours with us and joining us for day 3 of the first Academic Debates Madness Week. We hope you enjoyed participating and attending as much as I did. Tomorrow, both participants and the attendees will receive an email with a brief survey. We're also posting the link. Please fill it out. I think these debates, having watched them now for years, they do get better as people make suggestions, and we would like to do it then. And I hope you'll join us either tomorrow or Friday night for more academic debate madness. Thank you again, and enjoy the rest of your evening. Good night. God bless.